So hello there and welcome. My name is Tyler Best and I am one of the Springboard community managers. Today's webinar, The Pivotal Role of SBC in Quality of Care, is presented by Springboard, an online community under the Breakthrough Action project. Breakthrough Action is USAID's flagship program on social and behavior change and ignites collective action and encourages people to adopt healthier behaviors by forging, testing, and scaling up new and hybrid approaches to SBC. If this is your first Springboard webinar, then welcome. So what is Springboard? Springboard is an online community of over 5,000 SBC professionals from over 100 countries. Springboard can help you advance your SBC skills, connect with colleagues and SBC leaders, and get inspired through resources, events, and jobs. So if you're not a member already, join today. We'll be starting today's event with 3 presentations, followed by time for questions and answers. Feel free to use the chat feature on the bottom to introduce yourself and your organization. You may also use this feature to ask any questions for the speakers throughout the event. We'll compile those to use at the end during the Q&A session. Now on to the show. Our first speaker is Heather Hancock and comes to us from Breakthrough Action, where she's a senior program officer too. Over to you, Heather.
Thanks so much, Tyler. And hello, welcome to everybody. Good morning, good afternoon, good evening, wherever you are. I'm really excited to be here with all of you today to talk a little bit. I've been asked to introduce some concepts of quality and experience of care, and particularly how social and behavior change is a critical component of quality of care. So next slide. Let's start out by examining what is quality of care. Next slide. There are a couple of definitions that I think are helpful when we're thinking about quality of care. And the first is from the Institute of Medicine, now the National Academy of Medicine. And it talks about how quality of care is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with evidence-based professional knowledge. And I think it's interesting to point out here that we're talking about improving health outcomes, so that's a big component of it, and that there are elements of some sort of evidence-based practice. And David Nicholas adds some ideas to this definition and emphasizes that we need to pay attention to the whole continuum of care, what happens before a service interaction, during that interaction, and then after the interaction as well, can all affect quality. He also raises this idea that quality is connected to the larger system. So he talks about quality care being a function of the system's ability to do these things. And he also talks about it being responsive to client needs specifically. And all of these things are done in effective, responsive, and respectful manners. So we'll dive into some of these concepts in just a minute. Thanks, Tyler. So the IOM and WHO have identified key elements of quality of care, and those are listed here on this slide. The first is effective, meaning that there is evidence-based healthcare to those who need those services. The next is that care is people-centered, so it provides care that responds to individual preferences, to their needs, that are resonant with their values. Also, care is safe, so it avoids harm, excuse me, and it is also equitable, so providing care that doesn't vary in quality based on who people are, whether that's their gender, their ethnicity, where they live, the kind of location that they live in, their socioeconomic status, all of those things don't matter. They are treated equitably. And then care is also efficient, so maximizes the benefits of whatever resources are available and avoids waste. And then finally, it is timely, so there are no important delays happening. The wait times are reasonable. And then WHO also adds one additional element, which is integrated. So this idea that there is care being provided that uses the full range of health services throughout someone's life course. Next slide. So let's talk a little bit about some of the important concepts in quality of care. First one is that quality of care is really complex. It has many aspects to it, and it's influenced by various interacting factors. And like David Nicholas pointed out in that definition slide, it is the product of a larger health system and also the actions of lots of different individuals. So we think about providers contributing to this, clients themselves, community members, health system managers, politicians, all of these people are interacting and producing what would be called quality of care or lack of. And because quality is a product of the system, our efforts to improve quality really need to go beyond simple service delivery. We need to look at the larger system and focus on that system. The Institute of Medicine is famous for saying that the problems come from poor systems, not bad people. And a lot of efforts have focused on people, not the larger system. And unfortunately, what we find is when we don't focus on the system, those poorly designed systems will lead the workforce to fail no matter how hard they work. And so what we see is that there are abundance of evidence-based guidelines. There have been lots of different efforts, but still we see that in a lot of places, healthcare services are failing to deliver safe, effective, person-centered, compassionate care to patients when and where they need it. And so we've focused on a lot of important elements as we've done quality of care work, but there are still other elements that we may need to focus on to really ensure that we deliver that quality of care. So those things are necessary, but not sufficient. We also know that quality of care starts before the service interaction. So what David Nicholas said earlier, we can't focus only on the interaction itself, but we need to think about what's happening before a client tries to access services, and then what happens after and how they're supported. All of those contribute to the feeling of and the observance of quality. And then finally, we know that quality of care is very contextual and cultural, and so we need to focus on those contextual elements in order to provide care that is considered of high quality. Next slide. So I want to talk a little bit about experience of care also. And experience of care is a critical component of quality of care. The Barrel Institute defines it as the sum of all interactions that influence client, and I would also add provider, perceptions across the continuum of care. And experience of care includes elements like communication with providers and other staff at a facility and how those clients are treated. So are they treated with respect and empathy? Is their care culturally appropriate? Are they involved in making decisions about their health and their care? Do they have access to the services in the first place and other information that might impact the decisions that they make and how they adhere to guidelines? And then what do their friends and family members say about the care that they've received? And do they receive some sort of emotional support during their care? Research also shows that the experience of care influences overall health outcomes and care seeking. And this is one of those reasons why it's really important to focus on the whole continuum of care. So if someone has had, for example, a negative experience of care, that will influence whether and when they seek services in the future. And this can be vicarious as well. So if they've heard from neighbors or friends or family members that about their experience of care, that can also influence that client's care seeking in the future. We also find that client experience is strongly tied to client expectations. So what do they expect to receive from care? And were those expectations positively realized? And this is beyond just a clinical outcome or their health status at the end. This is really thinking about their experience. And while provider competence and adherence to clinical protocols is important, experience of care really highlights this idea that we need to focus on more than just excellent clinical care and positive health outcomes. We really have to consider, how does the patient experience that care that they're receiving? In one of the countries where we were working on respectful maternity care, and we discovered that providers, their main goal was to deliver a safe baby and to have a healthy mother. And that goal was so important to them that other aspects of care kind of fell to the wayside. And we discovered that in order to deliver a safe and healthy baby, that oftentimes that would justify, disrespect or ill treatment of the mothers. And in talking to the mothers, they said, of course, we want to have a healthy, safe baby, but we also care about these other things. We care about being treated with respect and kindness, and we want to know our options and all of these pieces. And so all of that is important in terms of experience of care, not just the ultimate health outcome. And in that same vein, it's important to move beyond simple satisfaction measures, because oftentimes we find that clients have low expectations, and so they might say that they are satisfied with care even if they didn't receive a very high quality of care or they didn't have a positive experience of care overall. And then finally, there is this idea that person-centered care is vital. It really does need to be individualized, and there needs to be tailored care. And then finally, I'll just add that when we're thinking about experience of care, it's also important to consider a provider's experience of care, not just clients. And so we need to think about provider well-being, stress, their burnout levels. That's also important in their ability to provide quality care. Next slide. So knowing that quality of care and experience of care are very complex and it's not an easy issue to tackle, why do we even focus on it? I think first and foremost, it's because we value humanity and we see the importance of providing the best care that we can in a way that improves clients' lives. And we also see that quality of care is a key element of achieving universal health coverage. And we also see that it can help reduce coverage, retention, and wellness gaps. So the ASSIST project really focuses on getting care to those who need it, that those who receive care stay in care, and those who stay in care do well in care. So those are really important concepts. And we also see that research shows that improving quality of care can improve health outcomes and the quality of life. More and more evidence shows that ensuring quality of care prevents death and disability. Next slide. So a few influences on quality of care. Again, I don't think this is a comprehensive list, but these are several of the elements, things like governance and policy. So the kinds of policies that are in place, the standards, the leadership and accountability mechanisms, financing. So what kind of funding is available for services, for the workforce, for training, and commodities. And then looking at supplies and commodities. Are there functional commodities and supplies available at the point of service? Is there technology or equipment available to do their jobs? The physical state of the facility, do they have running water? Is there electricity? Do they have private spaces for consultations? Provider behavior, and I'll go into that in just a minute. Clients and their behaviors, how involved are the clients? Do they feel empowered? What are their expectations? Do they have trust of the health system and providers? Are they willing to engage with the providers and share information, ask questions, all of those pieces? And then organization of care processes, the wait time, service flows, health information systems. So things like lack of, whether routine data are collected routinely to improve services and whether they have access to that information. And then finally, community. So the support structures and norms and accountability and ability to organize and get resources. Next slide. So I want to focus just for a moment on provider behavior. This is known to be a key component of quality of care. And provider behavior also affects the experience of care positively or negatively, depending on how professional, competent, courteous, compassionate the provider is. And we know that providers have a large number of needs in order to provide quality of care and a positive experience of care. And so we need to look at the system around the provider to think about what kinds of things are influencing the provider so that they can then provide quality of care. So it's not just their competence and knowledge and skills, but it's also what resources and commodities that they have, what laws are in place, what kind of support do they receive, the structures around them, the norms that might be affecting their care, their motivation levels. And also the great importance of trust, whether they trust each other as providers, whether they trust the client, and whether the client trusts them can really influence provider behavior. And then, as I said earlier, we really need to focus on provider well-being and think about them as individuals as well, who need support and need to have a positive experience of care. Next slide. So I'm not going to go over these in great detail, but there are some traditional methods that are applied to quality improvement. Things like training or supportive supervision, process improvement, audits and feedback, accreditation mechanisms, licensing and regulation, and standards-based management and recognition. So these are some of the ones that we typically see applied to quality improvement, and I'm going to add to that list with some particular to social and behavior change. So next slide. So let's talk a little bit about the role that social and behavior change can play in quality improvement and experience of care. Next slide. For those of you who may not be as familiar with social and behavior change, our definition of social and behavior change from Breakthrough Action is an intentional process that's grounded in social and behavioral science that seeks to understand and facilitate positive norms, positive behaviors, social norms, and influence the structural, contextual, and environmental determinants that enhance individual and collective well-being. So let's go to the next slide. So we really see that SBC is relevant for quality of care and improving the experience of care, because at its core, SBC is people-centered. It has various processes and techniques that help us to understand client and provider needs, their values, their preferences, and it engages those people in the design and implementation and evaluation of various initiatives that could help to improve quality. And so that understanding of people is so critical and goes back to WHO's and IOM's definitions. The elements of quality care is that it is people-centered. And then also SBC works across the continuum of care. You can see here on the right-hand side, there's the circle of care model that shows exactly how SBC can be used before a client even comes to service, during that interaction of service, and then after their interaction. And SBC focuses on the larger system, uses often the socio-ecological model to think about the different levels that we would need to work at in order to see the improvements that we hope to see. And so we can see those interactions across the levels and think about the larger system, from laws and resource allocation to access to services, all the way down to the individual level. And then importantly, SBC addresses some of those influences on quality care that have not traditionally been addressed. So a lot of great work has already been done on improving clinical competence, increasing resources, and those are critical. But there are also normative factors at play, attitudinal, various interpersonal pieces, and systems issues that have not always been addressed in quality of care. And SBC is uniquely placed to address those because of its focus on people and systems. And there are some really unique opportunities for SBC to build trust and compassion as well. And there's also a lot of evidence that SBC can enhance service delivery investments and that it does so with a high return on investment. Okay, so just really quickly, because I think my time is about up, I just wanted to add a few sample SBC approaches and strategies that can really help to change those behaviors, norms, and structures that are relevant to quality of care. So again, I'm not going to go through all of these, but these are a lot of things that SBC relies on that could be applied and have been applied in some cases to quality improvement, and really seeing that there is a better experience of care for people. So things like human-centered design process and audience analysis, that kind of I alluded to earlier, a lot of the provider behavior change work that has been done, looking at social accountability mechanisms and other community engagement, like community dialogues and partnership defined quality, fishbowl dialogues, various client empowerment mechanisms to ensure that clients come ready for an interaction with the provider, and various empathy and compassion building techniques. So I will let you sit with those and think about those a little bit and how we might better apply some of these SBC approaches and strategies to quality care. And I'll end just on the next slide with something that Breakthrough Action is testing a couple of different things in Tanzania. One of them is called the Tushikane Client Provider Package, and it really focuses on both the client side and the provider side simultaneously to really improve client-centered care and informed choice. And then the other one on the right is an initiative that is focusing on really providing compassionate care and focusing on provider well-being, as I was mentioning. And so these are two exciting things that you will keep you posted on in terms of thinking about improving quality of care from a couple of different angles that may not always have been explored. So I will pause there and hand it over back to Tyler. Thank you.
Great. Thank you, Heather, for that really great introduction to to this topic. So we're going to move on to our second speaker, Shanon McNab, who is a technical advisor for Momentum Country and Global Leadership. Over to you, Shanon.
Great, thanks. Hi, Taylor, and thanks, everyone. Good evening, some of us, afternoon and good morning. So I'm really looking forward to talking to you a little bit about the work that Momentum Country and Global Leadership is doing around respectful maternity care, respectful maternal and newborn care in particular, in relationship to SBC. So next slide, please. Great. So in my presentation, I'm going to talk a little bit about what respectful maternal and newborn care is, why there is mistreatment, why it exists, what Momentum has been doing in various countries to address mistreatment of women and newborns, and then some of the challenges and then next steps for both MCGL, but then the field more globally. Next slide, please. So what is respectful maternal and newborn care? Many of you have probably heard or seen the acronym RMC, where traditionally we've really referenced respectful maternity care, but we're now working very hard to prioritize the mother-baby dyad and really make sure that the newborn is part of this conversation as well. So we're using respectful maternal and newborn care. Respectful maternal and newborn care, it refers to, and I think this really flows nicely from Heather, your presentation, it refers to person-centered care that's organized for and provided to all women and birthing people, babies and families, in a manner that maintains their dignity, ensures freedom from harm and mistreatment, and enables informed choice. And our colleague, Patience Afolani, and some of her colleagues at UCFS have been discussing patient-centered maternity care, and they put forward tools that are really helpful in looking to understand and measure what types of care women are experiencing in facilities during facility-based labor and delivery. So women and newborns experience, or they're not an all or nothing, rather their experience exists on this continuum. So at one end is mistreatment, and on the other end is respectful and compassionate care. And I think a really important thing to notice and to make sure is clear here is that the absence of mistreatment does not necessarily mean there's respectful or compassionate care. And so also throughout the course of labor and delivery, a woman can experience both, and she can experience both by the same provider. So next slide, please. And so just to situate this in the larger quality of care framework, so in 2015, the WHO presented their maternal newborn health quality of care framework. You can see on the left-hand side, as well as the standards followed the following year. But the WHO framework for improving quality of care for women and newborns around this time of childbirth encompasses the provision and experience of care and key health system functions that are necessary in order to achieve high-quality health care. So on the left, you can see under this experience of care, there's three elements, and the second one being respect and dignity. So crucial for also for the work that we're doing in maternal mortality and morbidity reduction, but also for the very essence of it being a woman's experience. And as we will talk about a little bit later, how important that is. Next slide, please. So the way women and newborns are treated has implications for their physical outcomes, their mental health outcomes, but also, as was alluded to in Heather's presentation, their decisions to return and seek care in the future for themselves for postnatal care, for their newborn care, and then in any subsequent pregnancies. So much work has been done in the field for the past 14 years to understand and categorize and define what does disrespect and abuse or mistreatment, what does it look like? And to a lesser extent, there's been worked on, I think more and more the newborn literature is growing, but we've been trying to see what is it that women are experiencing that we want to address. So if you can see on the right-hand side of this screen in blue, there's 7 themes of mistreatment that were identified by the WHO. So this physical, sexual, and verbal abuse, stigma and discrimination, the failure to meet professional standards of care, the poor rapport between women and providers, and then health systems conditions and constraints. So you can see this sort of addresses the full spectrum of issues that women and health systems can experience, as well as providers. Next slide, please. Okay, so in 2011, the White Ribbon Alliance, which is an advocacy organization, put forward a very influential charter that states clearly the universal rights of childbearing women. The charter was amended in 2019 to include newborns, so it now includes both women and newborns. But the charter was, at the time, and still remains very important to those of us working in this space, as it grounded our call for respectful care as something, one, it was grounded in the language of human rights, right? This wasn't something that was nice or something extra on the side that was a feel-good element, that this was something that every woman and newborn deserved and was a human right. And the charter has also since been used in several countries and settings as both a tool for advocacy, but also a tool that can be adapted for facility or for different audiences for their own particular contexts. Next slide, please. Okay, so when we talk about treatment, why is there mistreatment? Sorry. So on the left-hand side are the types that I mentioned earlier, physical and sexual abuse, all the way down to health system constraints. But if you take a look on the right-hand side, you can see that the different types of drivers or the causes of mistreatment. And I think it's really important here to note, and this was alluded to before, that this isn't a case that there's so many social and environmental factors that drive and influence mistreatment. So it's not a case of a provider being bad people. Rather, this, as you start to unpack and look at the root causes of much of these types of mistreatment, their power dynamics, their gender norms and gender inequalities, social norms around stigma and discrimination, racism. There's facilities that exist without power, water, supplies, and drugs, limited staffing. And so there are many things that lead to and influence mistreatment. And it is complex and it is complicated to manage within the reality of the health systems that much of the MCGL countries that we work in. But there are definitely also elements of the interpersonal interactions that drive mistreatment. And so you will see here, and this is alluded to also in Heather's presentation, that there's so much that needs to come within the health systems approach, and it can't just be a one-off intervention to address some of these drivers. Next slide, please. Okay. So again, for many years, we focused on defining what is this? What is it we're trying to understand? What is it we're trying to change? And as we come to understand the pressures on the providers, the impact of the environment on their availability to be supportive and to provide the compassionate care that many were trained in, there has been a call to look at specific context of the facility, the health system, the community from which the women and the providers are coming, and start to take better care of the providers. So this notion of caring for the carers, to support the environment that they're working in while we're still centering the mothers and the newborns and their experience, but also recognizing it's really important that we take care of the carers as well. Next slide, please. So given this, what has Momentum been doing? We've focused on both. So really focused on providing, doing a lot of work that focuses on women and newborns, but then also the providers as well. So a lot can be done to support and help create this enabling environment for the providers. And most often, those providers that we are working with are midwives in order to provide the care that they want. And this enabling environment requires work at each level of the system. So the individual level, facility level, community, up to the policy level. And we've been working at each of these levels across many countries. Next slide, please. Okay. So this is just a really brief slide, and I'll break it into chunks in the next section, but just to show really that in each of these countries, we're trying to understand and work to support ministries of health and community-based partners to provide different levels of support to promote an enabling environment for providers as well as for women in communities. Next slide, please. Okay, so for example, at the national level, an important work that we completed recently in Rwanda was around co-creating. So I noted that HCD or this co-design idea, the language. So drafting together with relevant stakeholders within the ministry, partners, academia, what language needs to be placed into existing policies that includes respectful maternal and newborn care. So what do we need to make sure is said and placed in these existing policies? In Trinidad, it looks like there'll be some potentially looking at updating some of the guidelines to include some of these RMNC policies as well. But also looking at the human resources element at the national level is how do we integrate these RMNC components into pre and in-service training, as well as promoting and continuing to promote midwifery models of care and supporting the providers who are able to provide that care to women. Next slide, please. So at the facility level, a lot of work is being done in partnership with JPIGO to integrate some of the interventions that we have a solid evidence base for, such as birth companionship, right? Recognizing these facilities are overwhelmed, how do we provide someone for a woman to be there throughout labor and delivery when possible, and provide her the support that she needs? A very important element here is also the integration. So I think respectful maternal and newborn care has potential to be a siloed element of maternal, newborn, and child health care. And what we're trying to continue to do is to incorporate it into existing QI initiatives. So how can we make sure that RMNC is embedded in the existing work that facilities are already doing? And implementing MPDSR in many countries alongside with UNFPA and WHO. And at the facility level, engaging with CBOs to promote RMNC. Do women know their rights? Do community leaders know what women's rights are in a facility? And then introducing some of these accountability mechanisms that can ensure a two-way conversation between women and the community members with the facility to discuss women and the newborn's experience of care, as well as providers discussing their experience of care. Next slide, please. So what are some of the challenges? There's several challenges. I think all of us are aware of these, but creating an environment that will support midwives to practice as they are trained is often the desire, but it's really hard in these contexts that they work in. And addressing the drivers and the challenges at one level, such as providing a one-off training, isn't going to be a long-term solution. And so recognizing all of the constraints, but then also actively making a decision to work at as many levels as possible, I think remains a challenge in the work and in providing the type of supportive and enabling environment that women and providers deserve. Next slide, please. And I'll end here. So for next steps, globally, there needs to be, and there remains a gap in understanding how in the real world, right? So not in an RCT, but how do we continue to identify and understand how these things that are working, best practices, evidence-based interventions are being adapted and working within facilities and communities at policy level to really understand and then share that learning, including the newborn and consistently making sure that the newborn is seen as an individual, but also then part of this dyad. And then I think at the last point here really is continuing to actively engage with the social determinants. So recognizing that gender inequality, poverty, limited access to education matters and influences the community that we're speaking with, as well as the facilities and then the social norms. So I will end there and thank you very much.
Great. Thank you very much, Shanon. And last but not least, our final speaker here today is Angele Bienvenue Ishimwe, who comes to us from TIP Global Health. So over to you, Angele.
Thank you so much, Tyler. Thank you also. It is my honor to be here and discuss how TIP Global Health is promoting hope among healthcare providers and their recipient to increase quality of healthcare delivery and engagement in care in primary health care. Next, please. At TIP, we believe in power of relationship to strengthen health systems and deliver better health outcome. We envision a world where effective and engaging in primary care is delivered to everyone. We do so by delivering primary health care in rural resource settings, by utilizing data, technology, and the relationship to deliver lasting change. We also align patient, healthcare workers, decision makers, and donors to deliver effective primary care. We overall do that by delivering hope and engage patients in their healthcare journey. Next, please. Primary healthcare is often seen as a pathway to achieve the Sustainable Development Goal, as many speakers who have said, spoke before me has mentioned. But how does this work? In primary care, the approach is that it includes prevention, early diagnosis, early treatment, and the continuity of care. So what can we do to make this approach successful? A community member like Neza on the right hand needs to access care. She needs to receive quality care from the care provider who inspires her to adopt care. Also, she needs to remain continually engaged in care. So what is needed for this relationship to be sustainable is that we need to build a strong relationship between Neza and Yvonne on my right hand, who is a healthcare provider, so that this cycle of treatment continues. Next slide, please. Looking at the statistics in East Africa, we see that there is 50,000 of women that die each year in the process of giving birth. Child mortality elevates to over 2.5 million per year. In East Africa, women accessing care during their pregnancy are only less than 50%. And 70% of care providers are burned out. And these are the statistics before COVID. Now post-COVID numbers are even higher. Next. So why hope? I agree that there are many virtues that could drive a relationship between care provider and care recipient. However, research has found that we can't only fully explain the choices and the behaviors of people, especially vulnerable people. An individual choice or behavior regarding their health or livelihood, and even healthcare providers' quality of care are not solely influenced by external resources and information, but they are also explained by internal perception within themselves and their hope. That's what research is telling us. So according to Kay Hath, this is a nurse who did a lot of research about hope in primary care. Hope can be measured in these 3 dimensions: interconnectedness, ready for change, and future orientation. Hope is a foster for relationship and is also a precursor for behavior change. The presence of hope can predict the health outcome, while its absence can predict the poor health outcome. Luckily, hope is modifiable because it is a behavior and can be measured. Next. Also, looking at hope, we can see that it is an antidote, a direct antidote to burnout. As many have said, now there's a lot of burnout among healthcare providers, and this burnout is normally defined as depersonalization, emotional exhaustion, and the lack of a sense of accomplishment. On the other hand, the presence of hope is a great antidote to burnout. So next, please. What we did when we decided that hope is a good behavior that both health worker and the recipient can have to build a sustainable primary care approach. The first thing we did was to transcultural translate the Heart Hope Index in Kinyarwanda. Heart Hope Index is a 12 questions tool and was initially established or created by Kay Hath in the US, and it has been translated all over the world. So we also translated it in Kinyarwanda in 2020. And our translation has came up with replacing some wording response option to, as you can see on the pictures, some Likert scale that are visual, so that every Rwandan with every person from low resource settings with a low level of education are able to respond to these 12 questions. Next, please. The second step that we took after validating the tool was to really understand what are the factors that are influencing hope in healthcare settings. We asked 242 care providers and their recipient, and we understood, we came up in a qualitative research, we came up with different themes that they told us, but some of them are on the part of healthcare providers. Trust, learning, and passion for law was stated as barriers and facilitators for their hope. Also, on the part of care recipient, trust, social cohesion, learning, and so many other factors were stated as themes that are barriers and also facilitators to their hope. But though these are called similar names, but they are defining differently from the perspective of care provider to the perspective of care recipient. Next. So what we have seen by using socio-ecological model is that individual and interpersonal factors for healthcare recipient, we asked mothers, pregnant women, and mothers with children under 5. Their facilitators are like mainly they were trust, mutual respect, and mindset. This was set at most. For the part of barrier, mindset, mutual respect, and trust were stated as the most barriers for them to have hope. Next, please. If we go to the part of healthcare workers, individual aspect and interpersonal aspect as well were stated as facilitators of hope for them. Trust, mutual respect, and passion, as I was saying. But for the healthcare recipient, for the part of barriers, system was coming as first. So if we are using the socio-ecological model, this changed from individual to the interpersonal, and the first barrier came to system and interpersonal, where they stated system and infrastructure, while the first barriers to having hope. And mutual respect and leadership also was stated as barriers. Next. Hope was our initial theory of change was that hope optimized primary health care, which is still our theory of change. But the way we're thinking was that a hopeful healthcare provider will build a relationship with hopeful healthcare recipient. We believe also that hopeful healthcare workers will deliver high level of quality care to their care recipient, and this will increase hope to their care recipient, who in return will engage in care. This also will decrease maternal and child morbidity, which at the end will be able to achieve sustainable development goals. However, after our assessment, our qualitative assessment in 2020, next please, we learned that hope is something good that when we are acting upon it in terms of quality, we will see better results. So if healthcare providers are having what they need, if the system is there to address those factors or those themes that I've mentioned, this will increase the hope for healthcare providers. So, which means the system needs to provide what is necessary to providers so that they deliver quality healthcare delivery. We also learned that maternal hope is influenced by quality of healthcare that was received by mothers. Thus, factors that influence hope must include in the definition of hope. Next. So while refining our theory of change, we also needed to define hope in primary health care. So we had these two questions that we asked ourselves and responses to them. The first question was, how is quality defined from the perspective of patient? And the response was, let's ask them. So we are now developing a tool. Now, actually, we are on the phase of confirming the property of this tool called patient quality self-report, where healthcare recipient can provide their perspective about the care they have received. So this tool can be taken as one of the tools that are used to evaluate quality of care. The second question that we asked ourselves was, what does the health worker need from the system to provide the high level quality that is needed? So the solution was to know what are the gaps and what the health worker already have. So we are also developing a tool that is called Health System Optimization for Performance and Effectiveness, which is called HOPE, where healthcare providers can provide their insight on what the system is providing to them and identify gaps that are needing. We are also promoting or implementing the project called Resilience Messages that I will talk later. Next. For the patient quality self-report, which is a tool that healthcare recipient will evaluate the quality that they have just received, it has 6 pillars. There's clinical skills, where a patient can say what are the clinical skills a nurse was having on their perspective. There's patient-centeredness that has compassionate care, listening, personal lifestyle and medical history, things like that. There's education session, where a patient will talk about the ability of a health worker to provide health education, and also culture norms and beliefs will also be discussed for the education pillar. Linkage to care, where a patient is linking the care they received from the health center to the community, where community health workers are playing a bigger role, but also tools that can help a patient to keep having care in the household. Also, we have logistics, things related to logistics, like healing environment at the health center, and data management, which is stated receiving, where a healthcare provider can access data as well as a care recipient. Next. Next, please. Thank you. The second tool I was saying is HOPE, which has 4 pillars. The first pillar is leadership and management. The second pillar is workforce competency. Third pillar is system and infrastructure. And the fourth pillar is nurturing passion. This, like the first 3 pillars, can be found in many tools, especially in like healthcare provider satisfaction survey. But this pillar, the fourth pillar of nurturing passion, was a new pillar that we learned from the qualitative assessment, where we realized that nurses or healthcare providers need something that can increase their passion for or their compassionate care or their calling. So the system is not always taken as a burden, but what the system can also add to them, so that the passion they entered in the healthcare provider field is remain the same. Next. So the third, which is an intervention that we are starting implementing, is called resilience message. There's messages that will be sent to healthcare workers 3 times a week via a tool that that TIP already is using called eHESA. So to give a bit of a background, to increase the quality of care, TIP has created a digital data solution called eHESA, which is an app designed by frontline healthcare workers. And this app can be used on smartphone or a tablet. So healthcare providers are using eHESA to perform clinical activities. It captures essential data at the point of care to improve the health of care recipient by providing nurses with immediate insight to help personalize information and advise and help the mother to track the well-being of her child. So this application has now has a specific designated part for well-being of healthcare workers, where our healthcare workers will receive 3 messages per week. And those messages will either be related to stress management, mindfulness, personal and professional growth, connecting with others, as long as self-care. So as you can see on the top right, when a nurse is entering into eHESA in this application before providing care, they can see the number of messages that they have. They can choose to either read the message if they have time, or ignore the message and read them at their convenience when they have time. However, when they are working, the application has the ability to detect that they're swamped in work and can provide them with some prompt messages, such as this one that is reminding them to take a break and drink water. So they can also ignore it and continue their work, or reminding them to take that small break that they already need and do something for themselves. Next, please. So this work has been implemented in Africa, but we are expanding our reach to California with indigenous family from Mexico who came to California as agriculture workers and engage in care, and but they have poor health outcome because they are not fully engaged in care. As a result, they have a poor health outcome. So we are using a similar approach to define quality from the Mixteco community perspective. We are also defining system enabler from healthcare workers' perspective, but from California healthcare workers' perspective. So our plan is to utilize quality healthcare, is to utilize qualitative assessment by using a focus group done by, you can see Maya on the top right in green, who is conducting interviews in her community to learn more about what is defining quality on their perspective and how they can, what can be done so that they can engage in care. Lastly, we will be developing interventions and testing them. Next. Looking ahead, what are we planning to do? Our plan is to optimize already information that we have, because we have started developing them and implementing them. So we'll be optimizing them and utilizing the socio-ecological model that tackling interpersonal, individual, and system level interventions, and try to optimize them. The second plan is to look what about the main intervention that we have, which is eHESA that I talked about. We run a randomized control trial for eHESA to see if it can enhance quality in primary healthcare. Also, we will confirm the role of hope in improved quality of care and improve the maternal engagement in care, where we will be using Heart-Hope Index translated in Kinyarwanda to see if there is an increased hope when we are providing those interventions. Next, please. Thank you so much. These are our social handles, and I'm passing it to Taylor. Thank you.
Thank you, Angele. Thank you for that really interesting presentation. So we will go into a brief question and answer session. We've been compiling some of the questions so far, and we're gonna dive right in because it's almost the end of the hour. So the first one, this question from Jacqueline, and of course for everyone else, please feel free to add any additional questions in the chat as well. But Angele, we had a question from Jackie about how does reward and recognition fit into hope?
Thank you so much. I'm imagining that is for the part of healthcare providers. In the qualitative assessment we learned in 2020, that was stated more often, reward and recognition. Surprisingly, in terms of money, but in terms of leadership, recognizing the work of healthcare providers, the system recognizing the work of healthcare providers, and also recipient recognizing, like a feedback loop, or where the healthcare providers can see what they have done in the community, which is also one part of burnout, lack of a sense of accomplishment. So when we were learning qualitative assessment to understand the barriers and facilitators for hope, also lack of data, lack of access to data or access to information about what healthcare providers has done to their community was a barrier to their hopefulness, which was also leading to burnout. So one of the interventions is to see ways that community can be linked to healthcare providers so that those information can get to them easily. And if there's something that the healthcare providers can change, can be changed easily. And also the other intervention is to see the communication or leadership ability, where a leader is able to communicate on a timely manner and in a good way what a health provider has done. Because most of the time they are seen as people who are needed to provide care, to provide everything, to provide data on upper level, but they are not seen as people who are driving everything. So I acknowledge that question, and it is valid for hope. And when acknowledge, recognition are missing, the hope is really diminishing so fast. Thank you.
Thank you, Angele. I think moving back to a question that was posed earlier in the conversation from Anton, we have a question about malaria elimination, and just wondering from any of the speakers if they've seen quality of care being used for malaria elimination, or if that would be a useful tool here.
I would just add that I know I responded briefly in the chat, but I think that it certainly is, and there is a lot of evidence showing that SBC can be used in malaria programs. And I'm just looking for a link, but the Breakthrough Action Project has compiled an evidence database for the use of SBC within malaria programming. And if I can find that link, I will pop that in the chat for you, but that shows a lot of the evidence for using SBC to influence a lot of the behaviors around malaria and various elements of malaria, from malaria in pregnancy to, lots of different issues. I'm not a malaria person, so I can't speak super eloquently to that, but there are a lot of opportunities to use SBC within malaria and malaria elimination.
Thanks, Heather. That's great. I think perhaps since we're already over the hour, as our final question for any of the speakers comes from Janice, where they are working on some quality of care work in Malaysia, noting that because of the public system there, it doesn't always allow a patient and provider to choose one another. And this means that patients from different languages or cultures may be working with a medical provider and may struggle with some of these differences And the question is around if there are any SBC interventions that can be used to address this.
Tyler, I would add, I did put something in the chat about an activity that we have used and has been adapted in lots of different settings, which is called Pathways. I also think wherever possible, having opportunities for clients and providers to engage in some sort of way, whether that's through community dialogues or partnership defined quality or other aspects that bring them together and also help them to hold each other accountable. I think a lot of those sorts of elements are important since the element of choice in the first case is not possible. I think allowing them to interact with each other, see things from other people's perspectives, and work on group problem solving sort of things together, that would really help to increase their relationship, build trust, and improve quality of care overall.
Yeah, and I would just adding to that, so if you lift up a little bit longer term at the policy level, I think there's a lot to be done there too, right? Is how do we make sure that the providers more often look like and speak the language that the women or people that they're working with speak or look like. So I think there's so many different levels that you can tackle this challenge with, and some are much more long-term. Like how do we recruit and train and support people from different communities with different language skills to enter the workforce, become healthcare providers themselves, and then be supported in those, but then also have work at the facility and the community level. So I think this sort of speaks nicely to the different tiers of the health system that need to be addressed to take this issue on seriously.
Thanks, Shannon. That's such a great point. So we are about 4 minutes over, so I want to let our speakers go. But beforehand, I would just like to give them a huge thanks and round of applause from all of us for the wonderful presentations and for all of the fantastic back and forth in the chat. We will be sending out the presentations as well as a recording of this session within a day or two. So look out for that, and we'll be sure to also include all of these great resources that folks have been sharing within the chat. So thanks again to the presenters, and thank you all for joining. Be sure to watch out for future Springboard events in the near future. So thank you very much. Have a great rest of your week. Bye.